Hello everyone in CardioMinds channel, and today we are discussing a new spin-off video related to the essential medications in heart failure, and we are speaking about prescribing beta blockers. As we mentioned in the last video that our main reference is the supplementary data of the 2021 ESC Guidelines for heart failure, and an important note that we mentioned that these recommendations represent expert opinion based on relevant clinical trials and clinical experience, and these are the questions that we are going to ask today and try to answer: why, in whom and when, which and what dose, where, how to use the medication, some problem solving, and advice to the patients. We remember from the guidelines of pharmacotherapy that beta blocker has a class 1 recommendations for patients with stable heart failure with reduced ejection fraction to reduce the risk of hospitalization and death. So this leads us to answering the first question: why do we prescribe this medication? To improve symptoms and exercise capacity by reducing heart rate and so prolonging the diastolic filling time and the coronary perfusion time, to reduce risk of hospitalization by reducing heart rate and risk of tachyarrhythmias, and of course the main reason is increasing survival rate by upregulation of the beta receptors and also preserving the contractile power of the heart. The second question: in whom and when we prescribe beta blocker? The main indications are patients with stable heart failure, and we mean by the word stable dry avolemic patient, as we cannot start beta blocker in a congested patient. And the contraindications, the first one of course is second or third degree AV block in absence of a permanent pacemaker. Critical limb ischemia is unfavorable condition to start beta blocker. Bronchial asthma is considered to be a relative contraindication, and of course in presence of allergic reaction or any adverse reaction to a beta blocker. Regarding bronchial asthma, if we are using cardioselective beta blockers and are indicated in this case, so asthma is not necessarily an absolute contraindication, because here we are acting on the beta 1 receptors in the heart, not on the beta 2 which are present in the bronchi. But of course, the matter of selectivity is not absolute, and so they should be used under close medical supervision with consideration of the benefits versus risk according to the severity of bronchial asthma. And remember that COPD is not considered a contraindication. We are speaking about bronchial asthma, not COPD. Don't forget to be cautious in some situations like severe heart failure in a class 4, patients with current or recent exacerbation within less than 4 weeks, patients with AV block or heart rate less than 50, and also patients with hypotension with systolic less than 90, because we know of course that beta blocker act on the heart rate and also on the blood pressure, because they are commonly used as antihypertensive. And in patients with persisting signs of congestion like raised GVB, ascites, peripheral edema, try to achieve a volemic state before starting beta blocker, because we always start beta blocker in a dry patient. And some of the drug interactions that we need to look out for the risk of bradycardia: verapamil and diltiazem, which are of course contraindicated in heart failure with reduced ejection fraction, but in other situations you need to be very cautious about this combination and better to avoid it. Digoxin, of course, which is commonly prescribed in heart failure, has an added risk for bradycardia. Amiodarone, which is sometimes used to maintain sinus rhythm or in patients with recurrent VT, and ivabradine, which is acting on the SA node, resulting in increased risk of sinus node dysfunction and sometimes risk of AV block. Which beta blocker and what is the dose? We have 4 beta blockers approved in heart failure: bisoprolol, carvedilol, metoprolol succinate, not tartrate, and nebivolol. And we have a starting dose and target dose that we are trying to reach. Most of them are once per day, except carvedilol, which is used twice per day. Regarding the setting in which we prescribe beta blocker, the first setting of course is an outpatient setting in stable heart failure with reduced ejection fraction, and in hospitalized patient with worsening heart failure, but after stabilizing the patient, relieving congestion and restoring avolemia. And starting beta blocker should be ideally before discharge. Do not prescribe beta blocker on discharge, because sometimes you need to monitor the patient as an inpatient after starting beta blocker to check that there is no any deterioration regarding the heart rate, blood pressure, or heart failure symptoms. Let's revise some of the recommendations that we should follow while prescribing beta blockers. First of all, start with a low dose in a stable condition, and you can double the dose after at least 2-week intervals in the outpatient setting. And remember this rule: start low, go slow. You should monitor heart rate, blood pressure, and clinical status for any possible deterioration. Aim for the target dose or the highest tolerated dose as much as you can. And we mentioned that there is something called a specialist heart failure nurse in some country, which may assist with the education of the patient and helping him to titrate the dose and follow up his symptoms in person or by telephone. Now it's time with some of the clinical problems that we commonly face with beta blockers and how to sort them out. Asymptomatic low blood pressure is a common problem that does not require any change in therapy, just follow up. But in case of symptomatic hypotension, we follow the same algorithm as we've done in ACE inhibitors and ARBs. Dizziness is common, of course, and it often improves with time, so we need to reassure the patient. But if the patient is still symptomatic, we can reduce or even stop nitrates, calcium channel blockers, or other vasodilators. If the patient is not congested, consider reducing the diuretic dose. But if still symptomatic, in this case, we can stop beta blocker, especially if there is serious hypotension. Sometimes the patient may develop worsening of symptoms or signs due to the initial negative inotropic effect of beta blocker, like increasing dyspnea, fatigue, edema, or weight gain. And that's why we should always start beta blockers in a dry and euvolemic state. If the patient is developing increasing congestion, in this case we can try to increase the dose of diuretic. Patient is still congested, half the dose of beta blocker if the diuretic does not work. If the patient develops marked fatigue, which is a common side effect of beta blocker, in this case we can halve the dose of beta blocker and review the patient in 1 to 2 weeks. But we can sometimes be patient in order to reassure the patient that may occur initially and it may improve, but if it's still persistent, so in this case we need to halve the dose. If the patient has serious deterioration, for example, reaching the degree of acute pulmonary edema, of course, in this case, you can stop beta blocker, especially if it is recently started. And this drags us to an important rule that we need to check the onset of symptoms in relation to the start of beta blockers. For example, if the symptom deterioration occurred within 2 to 4 days of the start of beta blockers, so discontinuation may be needed according to the severity of symptoms, because most probably it is due to the negative inotropic effect of beta blockers. If the symptoms started within 4 to 7 days, in this case we can halve the dose of beta blocker and reassess the patient in follow-up. But if the symptoms started more than 7 days, in this case we need to check other causes for the patient's symptoms and try to sort them out before deciding to stop or reduce the dose of beta blockers. Bradycardia is a common problem that usually faces us with beta blockers prescription. First of all, reaching a target heart rate of 50 to 60 beats per minute is desirable for the symptomatic improvement, and also it has a positive impact on the survival rate. But if the heart rate is less than 50 with worsening symptoms, in this case we need an ECG to exclude high-grade EV block that may necessitate urgent stopping of beta blockers. Then we need to review the need for other rate-controlling medications like digoxin, ivabradine, and amiodarone, which are commonly prescribed for heart failure patients in order to stop them before stopping beta blockers. If bradycardia is still persistent, so we can halve the dose of beta blocker. But if there is serious deterioration like heart less than 40 or high-grade EV block, in this case, of course, stop the beta blocker. A common issue that we need to focus on is the sudden withdrawal of beta blockers that is sometimes performed by physicians, and some patients may do it wrongly. Of course, we know that the chronic use of beta blocker result in upregulation of the beta receptors, which has a positive impact on the myocardium and on the survival rate. And so, sudden withdrawal of beta blockade effect can result in robust stimulation of beta receptors, resulting in rebound tachycardia and positive inotropic effect on the heart. This may be dangerous in a heart failure patient, as it increases the risk of rate-dependent myocardial ischemia or acute heart failure, or risk of tachyarrhythmias like, for example, atrial fibrillation or VT. That's why the gradual weaning of the dose of beta blocker is recommended. For example, reducing the dose of beta blocker to the half, and then after 1 or 2 weeks we can reduce to another half or stop it, unless stopping beta blocker is needed for life-threatening condition like hypotension or bradycardia, or in case of acute heart failure. And finally, with the advice that we are going to give to our patients, we need to explain the expected benefits of beta blocker and tell the patient that the symptoms may take a longer time, within 3 to 6 months, to improve. We need to tell the patient that sometimes there is temporary symptomatic deterioration in the initiation of the beta blocker or dose up titration. However, beta blockers improve well-being in the long term. And finally, advise the patient to report any principal adverse effect like dizziness, fatigue, or dyspnea in order to decide what would be the appropriate plan. So our take-home messages at the end of this video that an air volumic state is essential before starting a beta blocker to have a dry patient, not a congested patient. And remember our golden rule: start low to start with a low dose and go slow to push the dose over 2 weeks intervals. Thank you very much for watching this video, and wait next week for the next spin-off video for the heart failure medications.